and welcome to Doctors in Court, the podcast where I take real medical legal cases and unpack them in a clinical lens. I'm your host, Dr. Sabine Fonderson, and today I'm going to dive into a case that raises a classic dilemma. When is wait and see too risky? This case involves an emergency physician, a patient with a ruptured tendon, a follow up that never happened, and a court complaint that could have gone either way. I'm going to talk about what happened, what the court said, and what the latest evidence tells us about diagnosing these kind of injuries. So let me introduce you to the patient. He's 42 years old, he's active, he's sporty, he's got no major health issues, and he plays amateur rugby on the weekends. One Saturday afternoon during a match, he suddenly feels a tearing pain in his left upper arm while tackling somebody. It's a classic mechanism. He shows up at the emergency department the same day and is seen by the doctor. She's a junior emergency department physician. She documents localized pain, weakness in the arm, and limited flexion. She suspects a distal biceps tendon rupture and tells the patient to rest, use a sling, and advise reassessment in 5 days. So far, nothing outrageous, but here's where things start to unravel. The patient doesn't feel reassured. He's still in pain, he's concerned about his strength, and he's worried something serious was missed. So within hours, not 5 days later, he actually goes to another hospital for a second opinion. And there, they order imaging, they confirm the distal biceps tendon rupture, and schedule surgery the very next morning. Let's fast forward a few weeks. The patient files a complaint. He says that the doctor in the emergency department missed the diagnosis. The doctor didn't explain the urgency and delayed his care. The patient feels that if he hadn't gone for a second opinion, his treatment would have been delayed past the surgical window, possibly limiting his recovery. Now, the doctor responds that she did suspect the rupture. She followed her hospital's protocol, which was conservative: to rest, to reassess, then refer if needed, the 3 Rs. She made that clear in the consultation, but the patient, he didn't follow up. She's supported by a trauma surgeon from the same hospital who confirms that this approach was standard at the time. So, what's the court's verdict? After reviewing all the details, the notes, the timeline, and the testimony, the court rejects the complaint. They say the diagnosis wasn't missed, the physical exam was appropriate for a first encounter of this kind of complaint, the follow up advice was clear, even if the patient didn't act on it, and although documentation could have been better, it wasn't negligent. So, no disciplinary action against the doctor, and she did what she was trained to do. But still, the case leaves me and possibly you guys with a lot to think about. Because what if the patient hadn't gone somewhere else? What if he had waited and the surgical window had closed? Let's zoom out a bit because what this case really highlights is the importance of clinical examination and the confidence to make decisions based on it. There's a good study from 2022 published in the American Journal of Sports Medicine by Zwieges and colleagues, and they looked at the diagnostic value of physical exams in distal biceps tendon ruptures, just like in this case. And here's the short version of the article. They studied nearly 100 patients who had suspected biceps ruptures and compared different physical exam techniques, including the hook test, the biceps crease interval, palpation, and a few others. What they found was pretty interesting. When you combine the hook test with the biceps crease interval, you get a diagnostic accuracy of 94% sensitivity and 100% specificity. That means if you do both of these tests and they're positive, you're almost certainly looking at a rupture and no imaging is needed. And that's pretty great to know. And it's a reminder that, especially in acute settings, we don't always need to jump to ultrasounds or MRI. Sometimes just doing a solid, well documented clinical exam is enough to guide decisions, or at the very least, to justify them in court later on. Now, did the doctor in this case do those specific tests? It's actually unclear. There's no mention of the hook test or biceps crease interval in the court documents. That's not to say she didn't do them, but if she had, and if they were documented, it might have shut her case down faster. So, what can we learn from this? First of all, this isn't about blaming a doctor for following a protocol. In fact, the doctor in the case did exactly that. She followed the system she was trained in. But what this case and this study reminds us is that protocol isn't a substitute for critical thinking. You can work within guidelines and still take initiative. You can document more precisely. You can explain the why behind your plan more clearly to the patient. And maybe you can say something like, hey, this could be a rupture. I've done the test. They suggest it might be. I'm recommending rest and reassessment because that's what we do here. But if anything worsens, or if you'd rather be seen by an orthopedic surgeon sooner, let me know or come back in later on. That conversation, it's that nuanced, can make all the difference in patient satisfaction, and it's actually going to help you avoid complaints. Let me ask you a few questions. Have you ever followed a protocol but still felt like you were missing something? And if you did, what did you do in that moment? Did you deviate from the pathway or did you stick with it? Here's a very small example. I recently saw a child with fever for one day, and the fever was quite high, up to 40 degrees. Parents had given paracetamol, and the child wasn't really feeling well. When they arrived to my clinic, I saw that the child wasn't feeling well. He was kind of lethargic, and he had a little bit of bronchi on his chest auscultation. Now, I didn't have any hard evidence that there was an actual bacterial infection going on, and I didn't do any other tests to make sure that it was or wasn't a bacterial infection. But based on the clinical findings, I just decided to treat the child with antibiotics because I felt the child had not enough, let's say, strength to get rid of his infection. And what was striking in the story is that 3 weeks prior, this child had been operated on his hand, and I felt that maybe because he had been operated on, it gone through surgery, his defense mechanism might be a bit slower. So I did deviate from protocol and immediately acted with antibiotics. Let me ask you another question. What's your confidence level with musculoskeletal exams at this moment? And be honest, when's the last time you did a hook test? Are we training junior doctors to lean on the exam or lean on the scan? So think about this for a moment, because if you end up in court, your hands and your notes are going to matter. So make sure you document everything and why you did certain things. The big takeaway: don't fear the physical exam. Invest in it, teach it, trust it, document it. And maybe most importantly, explain it to the patients. Not just what you're doing, but why you're doing, because that's how we keep people safe and how we keep ourselves out of court. I want to thank you for listening to Doctors in Court. If this episode challenged you or made you reflect, I'd love to hear your thoughts. And if you've had a close call or lesson like this in your own practice, reach out to me and let's keep the conversation going. Until next time, keep learning, keep reflecting, and stay real.